Good morning, everyone, to the February 2022 AIDS Clinical Conference. I'm just going to give it another minute or so as people join, and then we'll get started. All right, everyone, good morning. Welcome to AIDS Clinical Conference for February 2022. It's my pleasure to introduce our speaker, Geetanjali Chander, who is a professor of medicine and epidemiology at Johns Hopkins University. For now, she will be joining our UW community pretty soon as the division head for general internal medicine starting in July. So it's very fortuitous that she's here to speak today. She's actually currently the associate director for the Johns Hopkins program for HIV outcomes research and the research director for the Johns Hopkins Brancati Center for the Advancement of Community Care. She has, her work has spanned a number of years, particularly focusing on epidemiology, clinical trials, and her areas of interest are the intersection of HIV risk, HIV infection, and unhealthy alcohol use, which is what she's going to be speaking about today. So thank you for joining us.
Thanks. It's really a pleasure to be here. I'm very excited to present work I've done in collaboration with many folks from the University of Washington today. I do receive funding from the NIAAA. Since this is an alcohol talk, I thought I would acknowledge that. And I do sit on the HHS guidelines panels, and I'll be talking a little bit about that at the end of the talk. The objectives are outlined here. So just an overview of what I'm going to go over today. I'm first going to talk about unhealthy alcohol use and the HIV care continuum, and then its relationship with other comorbidities among people with HIV, provider barriers and facilitators to alcohol identification and treatment in HIV clinical settings, and then some practical thoughts about screening and interventions for alcohol use. So I'm actually going to start with 3 poll questions. They're not a quiz, but more so I have an understanding of where people are in the audience so I can modify my talk as needed. So when do you personally screen for alcohol use in your practice? At the initial clinical visit only, annual visits, or at every visit? Oops. Not sure if the poll question will come up or not. Okay. So it looks like, if you all can see the results, that we have a nice mix among all 3: initial clinic visit, annual visits, and at every visit. Okay. And then how often do you ask your patients about alcohol use when they have viral rebound? Almost always, often, sometimes, seldom, or never. Okay, and so we can see the results again, that a lot, almost always, and many sometimes. And finally, see if I can get the next slide. Oops. How often do you prescribe medications for alcohol use disorder when you diagnose an individual with alcohol use disorder and they don't have a history of withdrawal? Okay, and so what we see is over half, never, seldom, and 3% almost always. Thank you for sharing that. And so we'll go through much of this during the course of this presentation today. Let's see if I can advance my slides. Okay. So I'm going to briefly discuss a clinical case just so that we can contextualize what I'll be talking about over the next 40 minutes or so. So this is a 53-year-old man diagnosed with HIV in 2004. He established care in 2005 at an HIV clinic co-located with a substance use treatment program. He was initiated on epivir, tenofovir, and efavirenz with viral suppression for 2 years. He was subsequently then in and out of care, prescribed a PI-based regimen, which he did not ever start. He then had an 18-month full lapse of care where he had repeated hospitalizations for pneumonia and then re-entered into care in 2011. Past medical history was significant for an alcohol use disorder. He consumed 1 pint of vodka 4 days a week and weekend injection cocaine use. He had hepatitis C co-infection and tobacco use. These were his labs. When he came in 2011, he noted he did not want to start antiretroviral therapy. He wanted to go through detox first. He went through twice with continued use after each inpatient treatment. 4 months later, he asked to enter a 28-day residential program. Okay, so let's first talk a little bit about the spectrum of alcohol use. So alcohol use really is a spectrum. You have individuals with no use or those with low risk alcohol use, unhealthy alcohol use, which is also might call hazardous alcohol use, at-risk alcohol use disorder, recovery or low risk use, and remission. At-risk alcohol use is defined by the NIAAA as alcohol consumption for men at less than 65 years old, greater than 4 drinks per occasion or more than 14 drinks per week. And for women and men greater than 65 years old, greater than 3 drinks per occasion or greater than 7 drinks per week. This is with the caveat that these data, the definitions are based on alcohol drinking levels in cisgender individuals. There are not as much data on cutoffs for transgender individuals, though they do say we should use a cutoff of 5 drinks per occasion. Unhealthy alcohol use among people with HIV is prevalent. In the CFAR network of integrated clinical systems across 8 HIV clinics when this study was done, about 27% of individuals met criteria for unhealthy alcohol use. So though the next section really covers alcohol use and the HIV care continuum, I wanted to start and briefly talk about alcohol use and risk of HIV acquisition. And this is relevant because there are increasing data that alcohol use is related to HIV acquisition in the 3 major risk groups: individuals with injection drug use, those with male-to-male sexual contact, and those with heterosexual transmission. So in this study, in the ALIVE cohort, a prospective study of individuals with injection drug use, they found that 34% of individuals consumed more than 21 drinks per week. And that in fact, among those who consumed more than 21 drinks per week, there was an increased risk of HIV with a hazard ratio of 1.83. There are actually similar data to this among women and also men who have sex with men. This is a small study that was done in the Baltimore City Health Department among 671 attendees. They were queried about their alcohol use and their HIV transmission risk behaviors. 30% of women reported heavy episodic or binge drinking, and women with heavy episodic drinking engaged in anal sex at twice the rate of women without, and 3 times those who abstained. And I think importantly, gonorrhea was 5 times higher among women with heavy episodic drinking. And then there have actually been, we've seen similar data among men who have sex with men, but then there's also laboratory data where they actually bring people in and they give them alcohol use and then run through different scenarios and look at intention to have condomless sex. And really, there are a lot of data now that actually demonstrate this as well in the laboratory. And so people more and more are starting to really support this idea that there is some causality here. So moving really to the care continuum. So one of the earlier studies that we did, and this is now what I would say is an old study, it's 15 years old, in the Johns Hopkins HIV clinical cohort, was to really examine if hazardous or unhealthy alcohol use was independently associated with use of antiretroviral therapy, adherence, and viral suppression. At the time that this study was done, generally, all substance use was lumped together. And so in this study, among 1,700 individuals, we really wanted to see, is there any independent effect of alcohol use, or is it all just polysubstance use? And what we found was that among individuals with hazardous alcohol use alone, they were less likely to be on antiretroviral therapy. They had lower adherence and lower viral suppression. In more recent data from the Veterans Aging Cohort Study, they've looked at unhealthy alcohol use and the HIV care continuum. And among 33,000 persons in the study, what they found was that very high levels of alcohol use, and this is based on audit C scores of 8 to 12, was associated with lower viral suppression, lower treatment with ART, lower engagement in HIV medical care. Engagement in care was defined by having a CD4 viral load test. Treatment of ART was at least 1 filled prescription, and viral suppression was less than 500 copies. And I'm now going to present a few studies very briefly by one of my mentees, Katie Lesko, who's an epidemiologist, who has further looked at time spent with a viral load greater than 1,500. And so among individuals, this was again done in the Johns Hopkins HIV clinical cohort, who had unhealthy or hazardous alcohol use at baseline, they spent more time with viral loads over 1,500 after initiation of antiretroviral therapy. She also demonstrated across the CNIX, the larger HIV, multi-site HIV cohort that's run outside of the University of Washington, that when individuals were starting at a place where they weren't drinking, any increase in alcohol use was associated with subsequent viremia. And then among individuals with an alcohol use disorder, any alcohol use was then associated with subsequent viral non-suppression. So I think there are some compelling data here that not only does alcohol use impact whether or not someone is taking their antiretroviral therapy, but also that there are these greater impacts on viral suppression. And not surprisingly, I think for all of us, we know that adherence plays a huge role in whether or not an individual maintains their viral suppression. And this was a meta-analysis of 40 studies where they looked at the relationship between alcohol use and antiretroviral adherence. And what they found was that, not surprisingly, based on the viral suppression data I showed prior, that any alcohol consumption was associated with a decreased odds of being classified as adherent compared to those who did not drink. There have been more recent studies that have really dug into this and shown that there's really a temporal and dose response between alcohol use and adherence, where antiretroviral therapy is more likely to be missed on a given drinking day and the day after drinking, with a stronger association with heavy episodic or binge drinking. And this is probably multifactorial, related to the direct effects of intoxication, complexity of antiretroviral therapy regimens, and patient perceptions of adverse interactions between alcohol and antiretroviral therapy. Seth Kalishman has done a fair amount of work in this, looking at alcohol and ART interactive toxicity beliefs, and this idea that individuals will not take their antiretroviral therapy on days when they are going to consume alcohol. And finally, sort of thinking about the next part of the care continuum, retention in care. Another one of my mentees, Anne Monroe, did an analysis in Phoenix where she examined whether alcohol use as measured by the audit C was associated with lower retention in care. And so she used the Institute of Medicine definition of retention, whether or not an individual had 2 visits within 1 year, at least 90 days apart. In this sample, 37% of participants reported never drinking. 38% had moderate use, which was an audit C score less than 3 or 4 in men and women. And 25% had heavy use, which was described as an audit C score is greater than that. And actually retention was quite good, which is, not surprising in Phoenix. I think retention is good. It was 89% by the IOM measure. But I think, as we all know, when we think about sort of ending the epidemic in many of our clinical settings, it's, really getting to that last 10%. And what she found was that people with HIV with heavy alcohol use were 22% less likely to be retained in care. And individuals with binge or heavy episodic drinking were 10% less likely to be retained in care. And then, when we have individuals who are not virologically suppressed, we are interested in whether or not they are also having condomless sex as we think about, again, kind of ending the HIV epidemic. And this was a meta-analysis done now again several years ago, where they found that any alcohol use and alcohol consumption in sexual contacts among people with HIV was associated with about twice the risk of condomless sex. Okay, so I'm going to move from that. I think I've demonstrated there's a great deal of compelling evidence that demonstrates that unhealthy alcohol use is a barrier to optimal HIV care continuum outcomes. And I'm going to talk a little bit about comorbidities. And there are a lot of comorbidities, and that could be a separate lecture. So I'm going to focus mostly on some data related to hepatitis C and data related to mortality. It's not surprising that I would talk about hepatitis C, since so many of our patients have both HIV and hepatitis C. I wanted to discuss this study in the VAX cohort study because I think it really it provides compelling reasons for why we do try and treat everyone with HIV, irrespective of their alcohol use, and everyone with hepatitis C with DAAs. So in this VAX study of over 3,000 individuals, what they did was they actually looked at advanced fibrosis, defined as a FIB4 greater than 3.25 by level of alcohol use and by whether or not the person, it was a person with HIV and hepatitis C only, HIV only, or neither. And their alcohol exposure was in three categories. One was that did the person have an alcohol-related diagnosis recorded in the record? The next category down was whether or not, based on the audit C, the person met unhealthy or hazardous alcohol use versus non-hazardous. And what you see here really is a kind of stepped increase in advanced hepatic fibrosis by one, whether or not alcohol severity was greater, and two, whether or not an individual had both HIV and hepatitis C versus either alone or none, all compared to the none group, sorry, to be clear. And I think, we talk a lot about now in our field that, we need to give everyone DAAs irrespective of alcohol use. I think this is very compelling and shows why we should be doing that. And similarly, we need to treat everyone with antiretroviral therapy. This is another study that looked at overall and liver-related mortality by self-reported and provider-documented alcohol use among persons with HIV. And I specifically put this study into this talk because both the VA study and this study did actually pull provider documentation, whether it was coded by an ICD-9 code or abstracted from the medical record. And what you'll notice in both studies is that provider documentation of alcohol use really does predict poorer outcomes. And I think that's in part because we tend to document kind of when people have very heavy use, and we've noticed it. But in this study, what they found was that among individuals, so that people were categorized by whether or not on the audit C, they self-reported unhealthy alcohol use, and then whether the provider had documented whether or not the individual had an alcohol use disorder or hazardous unhealthy alcohol use. And if a provider documented hazardous or unhealthy alcohol use, those individuals had twice the mortality compared to those with moderate use, irrespective of what the patient self-reported. And then similarly, we saw an increase in liver-related mortality. And in the VAC study, another VAC study, and I put this one in here because I think there are some interesting clinical implications. They compared individuals with HIV to those without HIV, and they looked at mortality over time. And what they found was that among people with HIV who had an audit score of greater than 4, equal to 4, and greater than 30 drinks per month, so 1 drink per day, they had an increased risk of mortality. And among people without HIV, it was actually at twice the levels of alcohol use. So at an audit C of greater than or equal to 5 and 70 drinks per month, or approximately 2 drinks per day. And what's interesting about this is it does make you wonder, should we actually have lower cutoffs for alcohol use among people with HIV if we're seeing mortality at lower audit scores? I think that's a question that remains to be answered. There are lots of other alcohol-related comorbidities that we see in our patients. Alcohol use is frequently comorbid with depression, other mental health disorders, trauma, anxiety, comorbid with other substance use, methamphetamine, cocaine, marijuana, tobacco. I have had patients in my practice who have had waxing and waning use of alcohol, and I'll pick it up when their hemoglobin A1C goes from being controlled to uncontrolled. Relationships between alcohol use and hypertension, cardiovascular disease, cognition, and cancer. I'm seeing more and more head and neck cancer among my patients, specifically who have both comorbid alcohol use and tobacco use. So clearly sort of broad implications for also management of comorbidities among our patients. So, among people with HIV, unhealthy alcohol use and alcohol use disorders are associated with lower use of medical treatment, poorer medication adherence, HIV transmission risk behavior, liver disease progression, and mortality. And as such, really, implementation of evidence-based alcohol treatment strategies is critically needed within this group. And I think one of the issues is that most people in need of alcohol treatment really do not access subspecialty services. And this is for many reasons. Some are not ready to stop, some can't afford treatment, others are worried on how it will impact their job. Some people are unsure of where to go. And then there's, stigma. So given the potential barriers to accessing traditional alcohol treatment services, really thinking about integration of alcohol reduction strategies into HIV care and other clinical settings really may increase treatment access and improve HIV outcomes. And I think also, mitigate, important health disparities. And really treating alcohol use in the context of a chronic disease can really be a teachable moment. Over time, about half of people with unhealthy alcohol use quit without formal treatment, and 65% of them attribute this to a physical health problem. But there are a lot of barriers to integrating alcohol reduction interventions in HIV clinical settings. As a provider myself, we can be really busy. Sometimes we're just not sure what to do, or we're not confident in what we can do. Patients can be reluctant to disclose alcohol use to providers, fear of judgment, fear of stigma. And then there are lots of system level issues when we try and integrate interventions into clinic, including the clinic flow. Do we have optimal ancillary support? So this is actually, I'm going to present some data that we did as part of the Alcohol Research Consortium in HIV, where we did a provider survey actually across 8 HIV clinics. The University of Washington was one of them, through CNIX. And so we asked folks how often did they screen individuals for alcohol use in new patients. Did they drink? Most people ask at intake. And then we asked, how often do they use a formal screening tool, such as the CAGE or audit? And that was actually much lower. And that's important because there are data that really do demonstrate that if we use a formal screening tool, we're more likely to pick up alcohol use in our practice. We also asked if, how often in patients who drink but do not have alcohol problems, do you advise safe drinking limits? And that was actually, about 20-25%. And then in hazardous drinkers, now unhealthy is what we would use. How often do you advise them to cut down? And again, that was about 2/3. We're usually and always. And we asked in patients with alcohol dependence, and this was at the time that we were using the DSM-4, so in individuals with severe alcohol use disorder, how often do you treat them yourself without specialty consultation or referral? And most didn't, 70% didn't. And this makes a lot of sense to me and to a lot of us. We don't have a lot of resources in our clinic, and it can be hard if you don't know what to do. So when we think about integration, it's also really thinking about, who in the clinic is actually going to provide these services, and what can we as HIV primary care providers do ourselves. And finally, we asked about use of alcohol pharmacotherapy. And what I think was most compelling about this was really just that most individuals said that they really did not have enough training on the use of pharmacotherapy. There was some concern about insurance, some concern about, inadequate research perhaps, but it was really about the training. And so we asked individuals about their confidence in the ability to prescribe alcohol pharmacotherapy. That is on the top. And you can see it's very highly skewed towards the left. Most individuals were not confident, but actually extremely willing. And so I think, when we think about willingness, then it's okay, well, we need to figure out a way to increase confidence so we see more prescription. So I'm going to kind of shift to practical management then of alcohol use in HIV clinical settings, kind of thinking about what we've reviewed about integration of alcohol screening and intervention practices into our own care. And as I described at the beginning of the talk, alcohol use really does occur on a spectrum. And where an individual really falls on this spectrum determines the level of treatment that we'll give them. And so when we see someone and they have unhealthy alcohol use, they've scored in the unhealthy range on the audit, we do want to assess whether or not they have a mild, moderate, or alcohol use disorder, because that will determine whether we do brief intervention, whether we consider pharmacotherapy, other behavioral treatments, psychiatric care, and referral. So who should we screen? This kind of gets back to the poll questions. And all individuals presenting to care, I think that, as we saw that alcohol use is absolutely related to HIV acquisition. And so we do see a prevalence of about 1/3 of individuals consuming alcohol at risky levels. I would say generally screen at baseline, and if negative, repeat at least annually. And again, what I would say is that I do screen at every visit, but it's probably because of this is what I do. But also to really pay attention to when you see new viremia, viral rebound, transaminitis, blood sugars that were controlled and are not controlled now, if someone's had accidents, if they have depression, if they smoke tobacco, these are all linked. And so you can imagine that we might actually screen a fair amount. And what I found is because I just routinely screen for alcohol, tobacco, and other drugs at every visit, my patients just know I'm going to ask. And so it's actually really easy to screen. And you can use one question, one validated question. How often in the last year have you had 4 or more drinks, if it's a woman, or 5 or more drinks? And if it's greater than or equal to 1, you'll follow up with quantity and frequency questions. And if it's not, you can stop. And then what we'll often do is then I'll follow up with the audit C and clarify that alcohol also includes beer, wine, and liquor. So this is the audit C. I know in the Madison clinic, this is actually asked as part of the PRO. And so you're fed results back on this. I think one of the critical things is to, when I assess alcohol use in my patients, I do actually ask specifically what they're drinking, thinking about what is a standard drink. It's a drink with 14 grams of alcohol. And so it might be a shot of liquor, a glass of wine, a 12-ounce can of beer. But I think I always show this slide because this is actually, 40s are really commonly consumed in Baltimore. They're sold in the corner liquor shops and are cheaper than a bottle of water. So this is a picture of some 40s that were at the liquor store outside of the methadone clinic where I worked for many years. So just as a reminder, this would be at least 3.5 standard drinks. So someone might say I consumed 1 drink, but if it's 140, it might be 3.5 standard drinks. And if the alcohol content is higher, it would even be more. So, when we ask about alcohol use in our own clinical practice, sometimes we don't pick it up because because we make inferences or assumptions about responses. And some work done by Emily Williams at the University of Washington, it really reflects this, where they found that individuals who were, using the audit were changing how it was being asked, that people did make inferences or assumptions, you don't drink, do you? Or, and so really important, I think, just to kind of stick to the questions and to start with that single question screen. So there are ways to overcome the challenges. One is to give a self-administered questionnaire, is being done, I know, in the Madison Clinic by computer. What's nice about computer delivered screening is it's standardized and valid, and you can use validated screening instruments. It's proactive and universal. And so it ensures that all patients are assessed for their alcohol use without regard to provider expectations of use. So I think it kind of eliminates our unconscious bias of whom will screen and not screen. And computerized assessments are shown to increase the likelihood of disclosure of drug use. And I always bring this own example from my own clinical practice, where when I was working in the methadone clinic, and I had not screened someone for alcohol use, and she was new to my care, and I checked her lipid panel, and her triglycerides were in the 2000s, and it turned out she had a pretty severe alcohol use disorder. And it was really, I tell this story a lot because it was a reflection of my own bias, that I had just assumed she didn't drink. This was long time ago, about 2002, but I think a really important story. So management of alcohol use in HIV clinical settings. So the first thing is brief alcohol intervention. This is recommended by the USPTF for persons with unhealthy alcohol use. It can be 1 to 4 sessions. Feedback can be from 5 to 15 minutes. It includes normative feedback on how much the person is drinking and advice to cut down or stop drinking. And this is really presented in the context of recommended limits and health. So, I've noticed that your viral load is up. Let's talk a little bit about that and how alcohol use may be playing a role in this, or, oh, your hemoglobin A1C is up, or your liver function tests are elevated. So in a 2018 review of BI for unhealthy alcohol use demonstrated reduced number of drinks per week among persons receiving BI versus control. But it's really important to know that it's not generally effective in persons with alcohol use disorder. These are sort of the briefest components of BI: screening for alcohol use in all patients, assessing for severity. You want to know if someone has an alcohol use disorder, but then risks and consequences. And then advising, providing feedback on drinking and the medical, behavioral, or social consequences, and making a recommendation for cutting down. So we did a brief intervention for women with HIV in our clinic in a randomized trial of 148 women. This was a 2-session session. And so each session was about 15 minutes. It was tailored to women in Baltimore and based on Michael Fleming's Project Treat work. And it included goal setting, drinking diary, assessing barriers and facilitators to cutting down. And so this was in our clinic, and it was primarily women with incomes of less than $10,000, and only 40% were virally suppressed at baseline. And we actually found that 90-day frequency decreased among the intervention group compared to the control, with women in the intervention group significantly less likely to have a drinking day. We also found that heavy drinking days decreased, and we weren't powered to look at viral load, and we would have had to have recruited about 275 women, and we had 148 women. And a priori, we didn't power for this, but what we saw was, there at 12 months, I can't say much because we weren't powered, but we did have 49% virally suppressed. And we also found that adjusting for baseline number of days of condomless sex at the intervention group showed 61.4% reduction in the odds of condomless vaginal sex compared to the usual care group. And I'll say that, so we did this trial now, it's actually, I think, fairly old. We completed the trial, I think we published this in 2015. But with Vivian Go, we actually adapted the same intervention for individuals with HIV in Vietnam, and actually also had significant reductions in drinking days, heavy drinking days, and drinks per drinking day, and importantly, improved viral suppression. So we've replicated the findings in Vietnam and are actually tailoring the intervention for people with TB and HIV and unhealthy alcohol use in India. This is another study called Project Reach in Boston, and I'm presenting this because the BI study I presented was among women. This study was among men who have sex with men, and they found that a 60-minute intervention followed by 2 brief phone sessions resulted in significant reduction in drinks per week and in heavy drinking days. And in Health Call, this is a 3rd study done in a large HIV clinic in New York City, where they found that what they did is that individuals had a brief intervention followed by a daily phone call asking people how much they were drinking. And actually, overall, everyone reduced their alcohol use. But in fact, it was the individuals in the health call group who had heavy or alcohol use disorder reduced the most if they had health call. And I think what I'm trying to say here is that the brief intervention was effective, but among people with alcohol use disorder, the health call, the additional intervention actually had a significant impact on their reduction in drinking. Okay, I'm just looking at the time to make sure that we're okay here. So what do we do when brief intervention doesn't work? And so those are individuals with alcohol use disorder, thinking about medications. And really, we can use models from depression and smoking and opioid use disorder to think about pharmacotherapy for alcohol use disorder. And really, alcohol use disorders are a chronic condition. So medications target the neurotransmitters involved in the reinforcing and anxiolytic effects of alcohol use. They're beneficial in combination with non-pharmacologic therapy, including counseling and other behavioral therapies, and they can reduce relapse and help maintain abstinence. I was going to go through the reward pathway, but for time, I'm actually going to skip it, other than to say, alcohol use also, like other drugs, works on the dopamine reward system. So we have 3 FDA-approved drugs and many other medications that are not FDA-approved that people use. Naltrexone is the one probably that most of you are all most familiar with now, in addition to disulfiram, which we all learned about in medical school, but actually I don't use this in my practice at all. So naltrexone blocks opioid receptors, and it attenuates the positive reinforcing effects of alcohol consumption. It has been known to decrease heavy drinking days and relapse to heavy drinking, and decreases alcohol craving. This is a meta-analysis from 2014, where they pooled a number of studies and found that oral naltrexone was associated with a reduction in return to drinking, and that the number needed to treat to prevent return to any drinking was 20, and to return to heavy drinking was 12 for naltrexone. And just to put that into context, SSRIs for depression, the number needed to treat is 7 to 9. Statins for primary prevention for non-fatal MI, number needed to treat is 104. Okay, I'm not going to go over these in detail. Here are other studies of naltrexone among people with HIV. I think most important is really the second study in my eyes, because using data from the VA again, they were actually demonstrated that giving naltrexone was actually pretty safe in terms of hepatotoxicity. And so I think in their whole sample, they had 114 patients with HIV who had at least 7 days of oral naltrexone. There was very little hepatotoxicity. There was a total of 2 cases of elevation 5 times normal, and it stopped as soon as they stopped the naltrexone. So to prescribe naltrexone, the main contraindication is if someone is on opioids. And then you want to monitor LFTs post-initiation, and there are no known drug interactions with antiretroviral therapy. You can give it monthly as an IM dose or oral. We tend to use the IM dose in our practice. Acamprosate is another medication that is FDA approved for the treatment of alcohol use disorder. It has had moderate efficacy in European trials. This has not been replicated in US studies, but they have found reduced risk of any drinking among people who get naltrexone and an increased cumulative abstinence duration. You can't use it in renal insufficiency. People do have GI side effects, and similarly, no interactions with antiretroviral therapy. So thinking through kind of barriers that we may have, we have actually started to look at computer-delivered screening and intervention for unhealthy alcohol use in HIV clinical settings. Really with the idea that we can reach large numbers of patients in the clinic. They're perfectly replicable. They offer greater anonymity, and they can be tailored to patient preferences and characteristics. I'm going to very quickly describe a computer-delivered brief intervention for people with HIV with unhealthy alcohol use, because the Madison Clinic was one of the clinics involved in this study. So it used a bird as the counselor who counseled using a motivational interviewing style. He provided personalized feedback, discussed the pros and cons of drinking, and goal setting to reduce or stop using alcohol. People received 2 sessions, and this was based on the severity of their alcohol use. This is just to say that we included adults who had met criteria for unhealthy alcohol use. And no incentives were offered. People were just offered to participate in the intervention or not. And this is the algorithm that was used based on whether or not individuals had unhealthy alcohol use versus alcohol use disorder. And what you'll see is that they got different levels of care. So if they had unhealthy alcohol use, they got 1 intervention. If they had alcohol use disorder, they got a different intervention. And then when they came back, they did another audit C, and then they were stratified into a stepped care. They would step up treatment if people were still drinking to a higher intensity. And I think the key here is that actually, you know, unlike a lot of studies where you pay people and there's a social desirability to kind of self-report improvement, here what we found was that you know, people enrolled and they actually did well. What we found was that among people who completed greater than 1 intervention session, they had a reduction in about 11 drinks per week, which we found was clinically meaningful. I'm not going to go through the whole analysis, but we thought that was very promising. And so what we found was that, you know, among non-treatment seeking individuals who did not receive incentives, we could reduce alcohol use and have clinically meaningful reduction. This is another study that was actually integrated into VA HIV clinics, where they did a similar stepped care model, where they used pharmacotherapy, and if individuals didn't improve, then they offered a higher intensity of treatment. This was not done by computer, but a similar concept. Then they also found reduction in alcohol use, but I think even more importantly, improved viral suppression. Okay, I'm being very mindful of time, which is why I ran through those, but I want to actually spend 10 seconds on this slide. Sometimes our patients come and we don't really know what their resources are. And so the NIAAA actually now has this NIAAA treatment navigator. So if you have a patient in the office and they say, well, I don't really know where to go, and they want to seek treatment outside of the clinic setting, you can actually go to this website, plug in where you are, what your needs are, and up pops a number of treatment resources. And so I just want you to have that. And then just to sort of summarize what the guidelines say for people with HIV, with substance use disorder. Persons with HIV and substance use disorder should be offered evidence-based pharmacotherapy as part of comprehensive HIV care in HIV clinical settings. Ongoing substance use is not a contraindication to antiretroviral therapy. Persons who use substances can achieve and maintain viral suppression. And I would say, even though I showed you all these data where individuals did have viral rebound or didn't maintain viral suppression with alcohol use, we have very durable antiretroviral therapy. So we're not seeing the same kind of resistance that we would have seen in the past. And we really should start everyone on ART. Selection of ART regimens for individuals who practice unhealthy substance use should take potential adherence barriers and comorbidities, potential drug-drug interactions into account. And then I think we would all agree with this, ART regimens with once daily dosing of single tablets, high barriers to resistance, low hepatotoxicity are preferred. So back to our clinical case, after 28 days of residential treatment, the patient returned to the office. He initiated FTC, TDF, ritonavir and atazanavir. He was offered naltrexone for relapse prevention. He declined, continued to attend mutual support groups and engage actively with a sponsor. And over the last 10 years, he's maintained an undetectable viral load. He's now on Biktarvy. He was cured of his hepatitis C and he quit smoking. And he has not missed a single appointment in 10 years. So in summary, unhealthy alcohol use can interrupt steps in the HIV care continuum, complicate comorbidities and their management among people with HIV. Given the impact of alcohol use on HIV infection and comorbidities and US goals of HIV treatment as prevention, it's critical to initiate ART among persons with unhealthy alcohol use. Universal screening with standardized tools can improve identification of unhealthy alcohol use. And evidence-based alcohol reduction interventions can be implemented in primary care and HIV settings and improve HIV outcomes. And lastly, I showed you this picture at the beginning, and I'm coming back to it now with really sort of showing some of the interventions. But I think, I don't want us to forget that alcohol use occurs in a context, the context of comorbid medical conditions, but also the context of neighborhood, housing, income, and the multiple structural drivers of health that actually, I think, play a very large role in the health outcomes of our patients. And so, it is really about kind of thinking about the whole person. So I just want to acknowledge all of my collaborators who've contributed significantly to this work. And I'm happy to take questions. Sorry, I ran quickly through the end because I wanted to make sure we had a little bit of time.
Thank you so much. That was an excellent presentation and really good for us to really think about alcohol use disorder and unsafe alcohol use when we're not just initially screening patients, but ongoing conversations about use. We tend to focus on opiate use disorder and stimulant use disorder, but really not forgetting about screening for alcohol use disorder as well. There are a couple of questions. One question is, what do you think about encouraging individuals with alcohol use disorder to try long-acting injectable HIV treatment?
Yeah, so I think, it's funny. I think it would be great. I mean, I think what we need, we don't have a lot of data. It's interesting. I know that I believe there are current studies right now where they're looking at individuals, with active substance use disorders to really think about long-acting injectable ART. And I'm actually all for it. I know that we have to think about the tail related to the medications, but I absolutely think that people can come in. In my ideal world, I would say, can we use injectable naltrexone concurrently with injectable ART and sort of help treat the alcohol use disorder while concurrently treating the HIV? I gave you sort of in my cases, in some ways, the worst case scenarios, but what I would say is I have a number of patients who actually have, moderate to severe alcohol use disorder, and they take their ART every day, and we do have I will have these periods where they'll stop for a week, but for the most part, they take it. So I think it's a good option. Also long-acting injectable ART, and it's just a question of how do we ensure that they come back for their additional injections. But I think it's worth a shot. I have not tried anyone yet in my own practice, but we have a wait list for the long-acting ART.
Great. Yeah, I think the Latitude study is evaluating that, as you mentioned. So hopefully we'll know some results. We've had a hard time recruiting patients for that study because the oral lead-in was long and people didn't make it through the oral lead-in.
Yeah.
So, but in real world use, we might find that there's a difference. There's another question here that basically, we've been conditioned to highlight monetary related incentives as a motivator for recovery. And what would you say that the intrinsic values identified, a word that were identified by the participants in your studies, rather than these extrinsic motivators?
Right. Yeah, I think that's a great question. I actually need to reflect on that a little bit. So part of it is, I actually didn't show this slide because I rushed through the end, but we actually looked at who sort of, who agreed to participate, because this was non-incentivized. This was, and it was just up to the person. And the people who agreed to participate, interestingly, were people with heavier alcohol use, people with co-occurring mental health comorbidities, and slightly more people who were not virally suppressed. And so it reached a group of individuals who in some ways had already probably identified that there was a need, that they needed to do something about this, the alcohol use. And so it was intrinsic in a lot of ways. And so I think, I think that's what it was about. And I think that was sort of what was so compelling is the individuals who chose to participate were not treatment seeking, but clearly they had been thinking about it. I'm not sure if that's a great answer, but it is sort of what it was and what we were able to find. And it was an interesting intervention. We continue to we're running it in the Hopkins clinic now. And one of the things we do hear from folks, which is interesting, is that there's something about, they've been counseled about alcohol use in the past, but they heard it a little bit differently because it was delivered differently, and that they process the information a little bit differently, which I also thought was interesting. But I have to say, many people at the University of Washington did not love the bird, so we're looking at other avatars as we move this forward.
Thank you. One other question I had, if I don't see any others in the chat, is just co-occurring alcohol use disorder with opiate use disorder, and trying to treat that has been really challenging. And if you have any thoughts about how to approach that pharmacologically, just because our main go-to is not a great option in those patients if they have ongoing opiate use disorder or they're on opiates chronically for other reasons.
Yeah, I mean, it is hard. And that's where I may either, so the first thing I do is I really do try and treat the opioid use disorder. And for most of my patients, they really, they don't want to use naltrexone for both alcohol use and opioid use disorder because they're not necessarily quite ready to stop using opioids. And so I'm really, in that case, I really start first with talking about using buprenorphine and how do we kind of stabilize, if it's an unstable opioid use disorder, stabilize it. And then for the alcohol, I have not had tremendous success with acamprosate, but I do try it. And then that's where I may also have to bring in, what kind of additional counseling can we get the individual? Can we get them into cognitive behavioral therapy groups? It's tough because the medication the medication we use the most, we can't use for people, naltrexone for people with alcohol use disorder and opioid use disorder, unless they really are going to stop the opioids. The other, you can try gabapentin. We use gabapentin a lot here, but in a lot of places it is actually, it has a pretty high street value. That hasn't hit the same way in Baltimore, interestingly, because I often feel like most things have a high street value here, but for some reason, we haven't seen a lot of gabapentin diversion. But that's not FDA approved, and it would be off-label use and just kind of trying it.
Thank you so much. I don't see any other questions in the chat. I just want to say again, thank you so much for your time. And I really look forward to working with you in person when you join us at the University
Thanks
of
for
Washington.
having me.
All right. Have a great day, everyone. Thank you.